Assalamu alaikum. Good morning, everyone. Thank you, Dr. Ashwaq, for the introduction, and I would like to thank the scientific committee for inviting me to speak today. So my presentation is about steroid use in IgA vasculitis, or HSP. I have nothing to disclose. These are my outlines. So IgA vasculitis, formerly known as HSP, Henriksen line purpura, which are currently used, we use both names interchangeably. And during my presentation, I will use the two names. IgA vasculitis is the most common cause of systemic vasculitis in childhood. And as we know, it is characterized by polymorphonuclear leukocyte inflammatory infiltration of the small blood vessels, along with IgA1 deposits in the wall of arterioles, capillaries, venules, and as well as the renal glomeruli. So this is the IgA vasculitis criteria that all of us know. First, you need the purpura or petechiae, usually involving the lower limbs, which is a mandatory criteria, in addition to at least one of the following, and these are GI manifestations, MSK manifestations, renal involvement, as well as the leukocytoclastic, the evidence of leukocytoclastic vasculitis with a predominant IgA deposit, either by skin biopsy or renal biopsy. And of course, whenever we have atypical purpura, we need to go for the skin biopsy to show the IgA deposit. So in general, patients with IgA vasculitis usually require supportive treatment. However, some children require steroid for selected indications. The efficacy of a steroid in the treatment of IgA vasculitis has been debated over the last years. Although it is a common vasculitis, as we mentioned, in pediatric practice, still a well-designed control studies are lacking, and they thought this is because of the usual self-limiting nature of the disease. So we have these consensus-based recommendations, which was published by Cesar Ozen and her colleagues in 2019, guiding the diagnosis and the treatment of IgA vasculitis, in which 16 international experts from both pediatric rheumatology and pediatric nephrology develop internationally agreed consensus recommendations, and it was the first international evidence-based recommendation concerning the management of IgA vasculitis, and I used it as a reference for many indications during my presentation. There's an interesting and nice consensus evidence-based recommendation for treat-to-target management for patients with IgA vasculitis by our colleagues in Egypt, in which they mentioned more details in IgA vasculitis nephritis and the management of MSK manifestations. So I'll divide my presentation based on the indications for the steroid use in IgA vasculitis, and these include preventing the nephritis, treating IgA vasculitis nephritis, treating GI manifestations, MSK manifestations, cutaneous manifestations, and the role of steroid in other manifestations, and finally the role of steroid in preventing the recurrence of IgA vasculitis. So keep in mind that short-term prognosis of the disease depend on the GI manifestations, and the long-term prognosis depend on the renal manifestations or kidney damage. So for the role of steroid in preventing IgA vasculitis nephritis, as indicated by the SHARE recommendation, it's not indicated. The prophylactic use of steroid is not indicated for patients who have isolated extra-renal symptoms or isolated hematuria. And however, still we need to investigate for renal involvement at the diagnosis and through follow-up by measuring the blood pressure and urine analysis. So this recommendation was based on one of the largest studies, a meta-analysis, which was published in Cochrane Library for intervention for preventing and treating kidney disease in HSP, published in 2015. They found that there was no significance between the risk of kidney disease between the prednisolone and placebo group. And there will be an update of this meta-analysis in this February 2024 with initially a similar finding. So for patients who are affected with IgA vasculitis nephritis, first, as a background, we know that incidence of IgA vasculitis nephritis varies between 20 to 50%. Most common renal manifestation is the microscopic hematuria. However, mild proteinuria, nephrotic syndrome, nephritic syndrome, and hypertension can occur. And 1 to 2% will progress into end-stage renal disease. There are multiple risk factors that put the patient at high risk for nephritis in patients with IgA vasculitis, and these include older age, male sex, abdominal pain, GI bleeding, persistent purpura, relapse, thrombocytosis, or leukocytosis. So for patients who develop renal involvement should be treated with steroid as a first line, either oral or pulse steroid, depend on the severity of the IgA vasculitis. The SHARE initiative divided the HSP nephritis into 3 classifications: mild, moderate, and severe. For the mild HSP, you have a normal GFR with moderate proteinuria. Usually the urine protein to creatine ratio will be less than 250, while in moderate and severe, we have abnormal GFR and usually a persistent proteinuria, where the urine protein to creatine ratio will be more than 250 milligram for at least 4 weeks. We will differentiate the moderate and severe by the renal biopsy findings. In moderate, less than 50% crescent, and in the severe form, there will be more than 50% crescent on renal biopsy. And these are the indications for renal biopsy. So for the steroid use in case of IgA vasculitis, whenever we have a mild nephritis, it is indicated by the SHARE initiative to start oral prednisolone as a first line. Then a second line will be azathioprine, MMF, or pulse steroid. If you have a moderate nephritis, you will start with either oral or IV or both. And then the second stage, the other immunosuppressant. For the severe form, you will start the oral steroid, pulse steroid, along with cyclophosphamide. And of course, this is based on the whole circumstance and the patient condition. So there are specific recommendations for IgA vasculitis nephritis. These include that any patient with persistent or severe renal involvement should prompt a nephrology consultation, and renal biopsy usually is indicated in this case. And the SHARE initiative recommended to start ACE inhibitor or ARABs in case of persistent proteinuria. So there are several studies recently have shown that IgA vasculitis nephritis and IgA nephropathy share the same pathogenesis, which is a defect in IgA1 glycosylation. So after being exposed to an antigen, there will be production of circulatory galactose-deficient IgA1. This will lead to the formation of anti-glycan antibodies, which will lead to formation of immune complexes, which are going to deposit in the mesangial and glomerular injury. I mentioned this point to highlight this study, a research article published in 2016 about the steroid effect on the galactose-deficient IgA1 level, and it was found to significantly reduce the serum galactose-deficient IgA1 level, and this is thought to improve the renal outcomes. However, still we need a large clinical studies to prove this. And as we know, the future now for the personalized or individualized medicine, in which the genetic information will predict the drug response in advance, and this will help to provide a safer and more effective treatment for children. So how about the GI manifestations? GI involvement usually mild, self-limited, as we know, and requires supportive treatment. However, severe GI symptoms can occur in 10 to 20% of patients, such as intussusception, bowel perforation, and massive bleeding. So there was a multi-center randomized clinical trial showed that early use of steroid in HSP reduced the intensity and duration of GI symptoms and joint pain. Was published in 2006. There was another study, which was a meta-analysis based on a comprehensive review of the literature in 2007, where they found that steroid resulted in 5-fold increase in the odds of abdominal pain resolution within 24 hours compared to the placebo. Then a large multi-center observational studies showed that the early use of steroid was associated with statistically significant decreased hazard ratio for surgery, endoscopy, and imaging. So as acknowledged by the SHARE recommendations, steroid is indicated in case of severe GI involvement, and there is multiple case reports regarding the use of steroid in these cases. So for MSK manifestations, as we know, usually it is transient, and it is the second most common manifestation in IgA vasculitis. It's present in around 40 to 90% of patients. Usually they will present with arthralgia and can present with oligoarthritis, usually affecting the lower limbs. Usually this is managed conservatively. However, some patients can present with severe manifestations. And of course, it's not known to cause any long-term joint damage. So, as indicated by the consensus recommendations by our colleagues in Egypt, they indicate that any patient with arthralgia, bed rest, and NSAIDs are usually enough for treatment. Whenever we have severe cases in which the patient is unable to bear weight, a short course of steroid can be used. How about the cutaneous manifestations? Usually they present, as we mentioned, purpura, petechiae. However, other manifestations can present, and hemorrhagic pulli and vesicles are usually rare but severe manifestations. And keep in mind, or they found that the severity of cutaneous leukocytoclastic does not correlate with the visceral involvement. However, as we mentioned, that prolonged purpura is associated with higher risk of nephritis. So a proposed treatment suggested within the literature, which was based on single case reports and a case series, that steroid is recommended when you have a severe cutaneous manifestations, bullous or necrotic rash, and usually they use 1 milligram per kg per day. Other indications for steroid use in IgA vasculitis include orchitis, which occur in around 14% of cases. Also, cerebral vasculitis, pulmonary hemorrhage, and whenever you have these two manifestations, you should rule out other differential diagnosis. Regarding the IgA vasculitis recurrence, as we know, IgA vasculitis carries excellent prognosis in most children, and symptoms are expected to resolve within the first 4 to 6 weeks. Recurrence is estimated in 1/3 of the patients, and usually it takes place in the initial 6-week period and may occur as late as 2 years after the onset. There is no formal definition exists for the exacerbation or recurrence of IgA vasculitis. However, it is thought that it is usually a new flare of cutaneous or systemic manifestations in patient who was diagnosed with IgA vasculitis after being asymptomatic for 4 weeks. And whenever you have this, consider the diagnosis of FMF, especially in our area. No definite regarding the role of steroid in preventing IgA vasculitis recurrence. Till date, there is no definitive benefit for preventing the recurrence. In fact, in this study, they found that patients who were at high risk for recurrence in HSP involved the renal involvement, patients who received the steroid more than 10 days, and patients with allergic rhinitis. This is another study, clinical course of extrarenal symptoms in HSP, which was a prospective study published in BMJ journal. In this study, they found that the steroid helped to alleviate the symptoms. However, it did not change the clinical course of the disease, and there was no difference in the recurrence rate between patients who received the steroid and patients who received the placebo. And in this study, the risk factors for recurrence were patients who are over 8 years and patients with nephritis. If the steroid is indicated, the SHARE initiative recommended 1 to 2 milligram per kg per day, depend on the indication, usually given for 1 to 2 weeks, followed by appropriate weaning, usually over 2 to 4 weeks. IV methylbred at higher doses, usually used for severe manifestations, and always consider the cumulative effect of steroid.
2 minutes left.
This is a local study which was done by Dr. Abdu and his colleagues in Asir, in a retrospective study from January 2016 to December 2020. They found that pulse steroid was used in 45% of cases, and oral steroid was used in 23% of cases. The main indication for pulse steroid was mainly the abdominal pain with lower GI bleeding, followed by orchitis, upper GI bleeding, nephritis, and both orchitis and lower GI bleeding, and 5% had severe bullous hemorrhagic skin manifestations. So in conclusion, SHARE recommended using the steroid for severe manifestations, orchitis, cerebral vasculitis, pulmonary hemorrhage, and they did not recommend using the steroid to prevent the development of nephritis in patients who have isolated extrarenal manifestations. Thank you.
Thank you, Dr. Al-Bandari. It was extensive review. Thank you. Any question for Dr. Al-Bandari?
Thank you very much, Dr. Al-Bandari. Excellent overview. Did you come across about the long-term outcome after 10 years, 15 years of those HSP patients, whether they received the steroid or didn't receive steroid, as a long-term outcome and risk of future as an adult nephritis or any systemic illness?
There's one study mentioned that sometimes end-stage renal disease can happen after 10 to 20 years after having the initial episode of IgA vasculitis. And still, the using steroid for preventing nephritis in patients who are affected with nephritis still is an area of debate. I found multiple studies where they found no significant difference between using the prednisolone and placebo for preventing the proteinuria, and the opposite. There is multiple studies confirming the effect of steroid in using proteinuria. However, the SHARE initiative, they call for a high quality randomized clinical trial for specifically using the steroid in patients with IgA vasculitis nephritis.
Shukran, Doctora. Small question. Did you find any indication or predictive, as a predictor, the autoantibody positivity in HSP to consider steroid? For example, if a patient has ANA positive or ANCA, because it's not unusual, people, they ask for these autoantibodies. And those who have these antibodies, are they use steroid more than others? And what is the result?
Actually, during my literature review, I didn't come across this, but I believe whenever we have positive antibodies, we should revisit the diagnosis. And I believe they might benefit from the steroid, but I need to review this regard.
Thank you, Doctora, for a lovely presentation. Did you, I'm here. Did you read about familial HSP while you are reviewing the literature? Yeah, because in Kuwait we have familial HSP. We have a family who has the father and brothers, and they also develop nephritis and renal failure also. And this one point. The other point regarding the antibodies, positivity for antibodies in HSP. Like he's in HSP, but we found that he had a prolonged ABTT, in addition to positive lupus anticoagulant and antiphospholipid antibodies. While you are reviewing the literature, did you face any kind of presentation like this? Because although he's asymptomatic, except maybe one episode of epistaxis, but this happened with the second attack of HSP. The antibodies, he developed antibodies with prolonged ABTT. Even the question for everyone here, if you have passed through these cases, and although he's asymptomatic, the question, we will treat or not to treat?
دكتورة الله يعطيك العافية. We noticed an important marker that we have seen in a couple of cases with severe HSP is the factor 13, especially for those who got severe GI disease, or in the literature they mentioned even those who got severe IgA nephritis. So probably checking it will be a good marker, especially in those who got severe unusual type of presentation, because the patients we had, they had GI bleeding. One of them has erosive gastritis. So the lower the factor 13 was associated usually with severe manifestations, which would probably help you in directing the corticosteroid treatment early in the course.
Yes, I do agree. And they discussed the use of factor 13 as symptomatic treatment for
yeah, it
these
helps
patients.
because you used it in a couple of cases, either to use concentrate of factor 13, or you could use the fresh frozen plasma or cryoprecipitate.